Just reintroduce myself, Anthony Nappi. I'm the nurse liaison for the Virginia Impact Project. It's a VDH-funded project for infectious disease preparedness across congregate communities in Virginia. We are about to start our 11th of 12 webinars for our virtual learning series. Today is on hepatitis C, and we are happy to have Dr. Rebecca Dillingham from Sentara Martha Jefferson join us today. She did her medical training at Universities of Missouri and Virginia, and public health training at University of Virginia. She specializes in HIV and hepatitis C care and care systems, and she's an infectious disease specialist. So we are happy to have her here today. Welcome, Dr. Dillingham.
Thank you.
And we'll get started.
Great. All righty. Well, I'm just going to see if I can make the technology work correctly. Thank you so much for the invitation to present. I'm always delighted to have the opportunity to share about all of the amazing and exciting changes that there have been in hepatitis C care over the past 10 years. So actually, can everybody see my screen?
I cannot see it yet.
Okay, let's see here. Share screen. How about now?
That looks good.
Okay. Is it showing in presentation mode?
There it is. Yep, that's slideshow mode.
All right, great. All righty. So, you know, I see that we have a nice group here. I'm just curious if everybody would be willing. I know it can't be anonymized, and even though it can't be anonymized, I'd really appreciate it if everybody could just put into the chat what the first word that comes to their mind without thinking about it is with Hep C. Can't currently see the chat, so I'm trying to figure out how to be able to see that. But I know you all are putting them in. Oh, there we go. Okay. Okay, yeah. Sneaky, boomer, bloodborne. Yeah, anybody else? Chronic. Uh-huh. Anything else? Okay, well, I think that those are all really great answers. Certainly, Hep C can be really sneaky. We're going to talk about that. Historically, we've thought a lot about boomers, and that is definitely an important population to keep in mind. Bloodborne, absolutely, we're going to talk a lot about that. Chronic, yes, but I'm hoping that I can get everybody thinking about it as curable also. And needles, I think needles really important in terms of thinking about it in congregate healthcare settings in particular, but also relative to the stigma that is really associated in many people's minds with hepatitis C because of the association with unsterile injection equipment and substance use disorder. I am really grateful that you brought that out. I'm not sure which kind of needle you were referring to, but it does give me the opportunity to say that for this presentation, I'm not going to be talking as much about the syndemic of hepatitis C and opioid use disorder. While that is extremely important, but I do want to emphasize that part of my talking about Hep C is always trying to reduce that stigma and helping people to remember that this is indeed a curable disease, and I'd like to get it out of those sneaky shadows so that we can get people feeling better. So thank you to all of those who answered. I'm going to come back to this too, but Virginia Hep C is also a VDH funded program. that I am privileged to lead along with my great colleague Terry Kemp-Nick. We are really committed to both curing Hep C in practice, but also to helping others learn more about it. So I will say more if you get really intrigued and would like to add curing Hep C to your practice, how that can happen. All right. So big questions. What is hepatitis C? What does it do to the body of someone infected with hepatitis C? Is hepatitis C an important problem in our community? Who should be screened? How do we cure Hep C, and why should we treat it? Because as somebody already noted, it can be kind of sneaky. Many people don't have any symptoms. So is it really worth treating at all? I'm going to argue very much yes. Anthony shared with me that the group is pretty mixed. So I've tried to have a balance of more clinical and more general slides. But if anybody has a question, because maybe I'm using too much medical jargon, or if you have a question because you'd like to know a little bit in more detail about a medical aspect, please just put those in the chat. And Anthony has said that he will help me monitor that, and I'll try to answer them in real time. No reason for this to be particularly formal. And just so you know, there is going to be some more audience participation with some questions, so get ready. So a lot of people think about hepatitis C as a virus that attacks the cells in the liver, and certainly that is true. As we go on, I'm going to challenge that a little bit, but for sure, hepatitis means inflammation of the liver, and that is usually how we suspect that a patient might have it, is because they have a slight elevation in their transaminases, their AST or ALT, and we start looking for it. Just as a reminder about why the liver is so important, it processes nutrients, filters the blood, produces really important proteins for blood clotting, for example, and it also helps us to fight infection. So, I mean, I don't think we have any organs that we absolutely don't need, except maybe the appendix, but this one is a pretty important one. In the traditional understanding of hepatitis C, and by traditional, I don't mean wrong, this is definitely one of the major issues with hepatitis C, is that it can lead to significant scarring of the liver, which I'll walk you through in just a moment. On the upper left, you see a nice healthy liver. It's usually a very spongy, soft organ. As there is inflammation for any reason, whether that's alcohol, excessive fat in the liver, or a virus, you can move from left to right and have the development of chronic hepatitis, which is visible on ultrasound and also on CT scans. Ultimately, if that inflammation leads to scarring, you come down to the bottom right and have cirrhosis. At that point, the liver is no longer nice and spongy. It's actually quite hard, and it actually usually shrinks some. So really, these livers should be smaller in size. Ultimately, some people, particularly those that have had viral infections, may be more at risk of hepatocellular carcinoma. Many viruses are what we call oncogenic, or able to provoke cells to divide abnormally, which can lead to cancer. And hepatitis C and hepatitis B, both viral hepatitis that can become chronic, can cause hepatocellular carcinoma. If you look at the box across the bottom, you'll note that while hepatitis C can sound pretty scary, actually in many people, and this is a relatively new understanding, in many people, the virus will clear on its own in about 50% of people. So we're going to talk about testing and interpreting the tests soon, but it is important to remember that people may have been exposed to the virus, they may have an antibody to hepatitis C, but many of them will not actually have active hepatitis C. Of those who end up having chronic hepatitis C, so the ones that did not clear the virus on their own, anywhere between 5 and 20% of those people will develop cirrhosis if the hepatitis C is not treated. And of those who develop cirrhosis, a small proportion of them will develop cancer. So obviously those are significant consequences, and yet they're also happily kind of rare. But as we move through this presentation, I'm going to talk a little bit more about some of the reasons beyond the liver to consider strongly treating hepatitis C. So just to recap, hepatitis C is a virus. For those of you who are really into viruses, it's a single-stranded RNA virus in the flavivirus family. It is the most common bloodborne infection in the US. I'm going to give you some more Virginia-based data in just a moment. And importantly, while I just emphasized the effects that hepatitis C can have on the liver, it's now understood to infect many other types of cells, especially white blood cells, which of course move through the whole body. These are some of the extrahepatic effects of hepatitis C. They include worsening or even initiation of diabetes. Oops. Glomerulonephritis, so a dangerous disease of the kidney. Essential mixed cryoglobulinemia, which is a blood disorder that can be caused by hepatitis C. Did the slideshow just stop when I dropped that?
It just popped out of slideshow mode. It's still visible, but there we go.
There we go. Porphyria cutanea tarda, which is kind of fun to say, not fun to have, which is a terrible skin rash, lymphoma, brain fog, which is probably one of the most common things I hear and most distressing, and extreme fatigue. And probably many of you have experienced in your clinical practice or perhaps in amongst people that you know, this is not fatigue like, oh, just kind of don't feel like mowing the lawn today. This is really fatigue where people just day after day really struggle to get out of bed. Very pathologic fatigue. The other thing that I think is important to mention is related to that stigma that I mentioned before. I was really privileged to get to work with some anthropologists at UVA to do an ethnographic study in collaboration with community members down in far Southwest Virginia who shared with us about the experience of living with hepatitis C. And you get the sense when you read this quote that this gentleman, it just dominated his whole life thinking about how and whether and if his family members got hepatitis C. Now, of course, we're going to talk about how you get hepatitis C, and none of the ways that he's talking about that he's worried about are ways to give somebody else hepatitis C. But this just resulted in him being so isolated and really limiting his contact with his grandchildren. And this is not at all a unique experience. So those kinds of misunderstandings about the disease, coupled with the real stigma associated with the diagnosis, can really result in people feeling pretty emotionally miserable. So let's talk about how common this is. So as I mentioned, it's the most common bloodborne infection in the United States. About 2.5 million Americans have active hepatitis C. The pandemic has really limited our ability to get new information on the number of new infections. So you'll see that this data is a little bit old with the 107,000 in 2020. Unfortunately, it's estimated that instead of going down during the pandemic, that the rates actually probably went up. In addition, you'll see on this graph where the orange line represents women with hepatitis C, and the blue line represents men. So more common in men. You'll also notice this sort of double hump. So the hump farther to the right represents the baby boomer generation. And we don't completely understand why they have such a higher rate of hepatitis C. Some of it may have been experimentation with substances. Other parts of it may have been lapses in medical hygiene and cleanliness, especially prior to the discovery of the virus of hepatitis C, which was in 1982. But that population does have a higher proportion of people with hepatitis C. Unfortunately, over the time that I've been doing this population on the left has really grown. This population, you'll note, who's aged between age 20 and 40. And that population is related directly to the opioid use disorder epidemic and the lack of access to sterile needles and other supplies, and also importantly, the lack of access to treatment for opioid use disorder. So acute hepatitis C, just to say it another way, had doubled in the period from 2013 to 2020, which is pretty dramatic. And I kind of shudder to think about what we're going to see when they finally get the numbers for the first part of the 2020s. These are maps created by Virginia Department of Health that show the progression of the prevalence rates of hepatitis C over time by county in Virginia. And you'll see that as early as 2013, the far southwest part of the state was disproportionately affected. That disproportionate effect has continued in the far southwest, but you'll notice that it's essentially spread across the whole state. The Piedmont also is now very affected. We're waiting on the most recent map. I do not anticipate that it will be better. Unfortunately. So in answer to my question at the outset about whether this is an important question in our communities, it absolutely is, and across the lifespan. I actually don't think I have a slide about this, so I'll just say it now. Since I mentioned the lifespan, there is a risk of transmission from mother to child. That's about a 6% risk. So even babies can be affected. And as we noted, I think some of you are probably from long-term care facilities for elders, and certainly that baby boomer population can be affected. All right, so how do you get hepatitis C? Just to review, you saw in that quote before from the gentleman in far southwest Virginia that he was worried about people eating after him. That is absolutely not a way that you can get hepatitis C. You can get it from sharing non-sterile drug injection equipment. And I'm realizing that I should have added something here. You can also get it from sharing non-sterile drug snorting equipment. So this is something that I find is important to remind individuals of, because I had a gentleman in my clinic just yesterday who had switched from injection to snorting because he thought it would be safer, but it's actually not if you share straws or bills, which may have microscopic amounts of blood on them. So I expect that he was infected actually from sharing insufflation devices. So that's another important way. Oh, and there I have about mother to child, about 6% of babies born to mothers. Healthcare exposures. I'm going to do a case in a minute about a healthcare exposure, just since I'm talking to people from congregate care centers. But I do want to underline that that's quite rare for people to get hepatitis C from healthcare exposures. It's also important to know that sex with an infected person is not a great way to get hepatitis C if it's vaginal sex. Anal sex is a different matter, can be, that is a higher risk kind of sex, but it's pretty rare, almost vanishingly rare for people to get hepatitis C through vaginal sex. Certainly unregulated tattoos or body piercings. It's important to remind people not only of the needles, but also ink. If people aren't using single use ink vials, the ink can also house hepatitis C. That can be the same thing if there are multiple use vials of medication. Sharing personal items, and by personal items, I don't mean towels. What I mean are personal items that might break the skin. So razors, just in general, as an infectious disease doc, not a good idea to share razors with anybody else. Toothbrushes, also not a good idea to share toothbrushes. But sometimes people don't have a lot of choices. So sharing razors, toothbrushes, other things to think about are tweezers, nail clippers. We're really talking microscopic amounts of blood. And so we ask the folks that we work with, once they have started treatment, to swap out all of those materials about 2 weeks in. And then blood transfusions or organ transplants before 1992. Okay, how will you know if you did get hepatitis C? Well, the answer is that you probably won't. I really liked that sneaky that someone put in the chat earlier. Yeah, hepatitis C, most people do not turn yellow. It is quite rare for people to have an acute hepatitis where their liver is swollen and painful. Most of the time, people just don't know. Unless, of course, you get tested. And just to remind everyone of the CDC guidelines for testing, every person over 18 is supposed to be tested at least once. So if you haven't been tested, you should be tested. Pregnant women now in Virginia, all pregnant women, it's recommended that they should be tested. If you currently inject or snort drugs or have ever injected or snorted drugs, a single use can definitely be enough. Do you have HIV? Particularly important to know if you have hepatitis C, if you are living with HIV, because hepatitis C progresses more quickly. If your doctor notices abnormal liver tests, people on hemodialysis are checked regularly. This is a pretty durable virus, and even with the really excellent infection control practices in most dialysis units, the virus still sometimes very rarely breaks through. So people on hemodialysis are regularly tested. Donated blood or organs before July 1992, have been exposed in a manner that I just described, where you've actually been exposed to someone's blood who has hepatitis C, or were born to a mother with hepatitis C. So I alluded to this before. What does the hepatitis C test for? Typically, the first test is for an antibody to hepatitis C. And as I note there, that tells you that the body has been exposed to hepatitis C and has built antibodies to try to fight it off. Unfortunately, hepatitis C antibodies are not protective. They are not strong enough to fight it off. And so they do not indicate any kind of protection against future infection, which is an important thing to remind people, that even if they cleared the virus once or they've been treated, they can be infected again. As I mentioned before, not everyone with antibodies to hepatitis C virus has an active hepatitis C infection. And I think most places are now, I believe UVA is, I know Sentara is doing a reflex. If you have a positive hepatitis C antibody, then it reflexes automatically to a hep C viral load, which is really helpful, so that you don't have to get the person to come back for another test anymore. And that's what you want to know. You want to know, does the individual have an active replicating virus in their blood? Okay, so I want to talk now about if you've been exposed to a person who has hepatitis C, and particularly in the case of healthcare worker exposure. So you all probably know this data better than I, but there are about 12 healthcare personnel blood and body fluid exposures per 100 average daily census days. So it's not a completely rare thing. It is thought to be similar in nursing homes, clinics, EDs, and home health agencies. And there is an increasing incidence of acute hepatitis C in the population at large, and it was already the most common. So for that reason, it's really important to think about how to manage evaluation of the source patient and also the person who's exposed in the case of blood or body fluid exposure. So this is a case that I actually saw in practice. It's a little bit modified just for the purposes of education, but pretty close to what actually happened. So 36-year-old nurse recapped a hollow bore syringe. He knows that he should not have done that. That was used to draw blood. The patient was septic, hypotensive, and also had multiple track marks on her body, and acknowledged that she injected drugs. She had no other significant medical history, and the nurse's wife is 26 weeks pregnant. Okay, the guidelines and the questions that I'm going to ask are derived from this guidance, which is what I use when there are exposures like this, and which I would encourage anybody to look at if they haven't, in terms of thinking about exposures to hepatitis C virus. So here's another opportunity to put something in the chat. So what should we do about testing the source patient? You can put in 1, 2, or 3 in the chat. Nobody wants to answer. Hep C antibody, 3, 3, 3. Okay, good. All right. So I agree with that now, because most antibodies reflex to a viral load. So the technical right answer is to test for Hep C RNA, but the good news is in most places you don't have to remember that anymore, because if you test for the antibody, if it is positive, it will reflex to the RNA. So I think that 2 or 3 are appropriate answers in this case. And I know in our system, it's actually hard to find the Hep C RNA test anymore because of that reflex. So it's easier just to do the Hep C antibody. And just to review, the reason that just testing for the Hep C antibody isn't correct is, remember that about 50% of people clear on their own. In addition, somebody may have been treated for hepatitis C. So if they just have the antibody, you don't know whether or not they actually have active infection. If they only have the antibody and the RNA is negative, then you're actually done. So you'll see that you all chose essentially option B, which is fine. So the anti-Hep C antibody test, if it's negative, you get to stop. If it's positive, then you need to have, this stands for nucleic antigen test for Hep C RNA. Then you need to assess whether or not the source patient has an active virus, so that would be positive, or is negative. If that person is negative, then you get to stop. If you don't have a nucleic antigen test, then you need to refer, you need to assume that the test was positive. Now, the other option, if you can figure out how to order it, which I generally can't, is just to do the Hep C RNA. And then if that's positive, we're going to talk about treatment. If it's negative, you get to stop. Okay. So the source patient has a hepatitis C viral load that is positive at 8 million copies per milliliter. That's a pretty common amount of virus. The virus is incredibly prolific in many people's bodies. And I'll pause here to mention, just so you know what it's like to have hepatitis C to a certain extent. If you imagine that there are 8 million copies of a virus in a milliliter of blood, what that means is that the person's liver every day is creating billions of viruses. And so the energy required to manufacture that number of viruses is enormous. And that helps to explain why people feel so exhausted and terrible when they have hepatitis C. Okay. All right, so this gentleman had a hollow bore needle exposure, and the needle had been used for already in a person that we know had hepatitis C with a positive viral load. So how about here? I changed it from numbers to letters, but what do you guess is the percentage risk of acquiring Hep C from a percutaneous exposure? C, lots of C's, C, okay. Yeah, thank y'all for participating. Yeah, that's what I thought too. But actually, newer data suggests that it's more like 0.2%. So I think that the safe thing to say is it's somewhere between 0.2 and 2%, but honestly, the newest data suggests 0.2%. So that's reassuring. So we're glad to know that. I think that if you're speaking with someone, if you're counseling someone that's had an exposure, it's important to remind them that only 2 out of 1,000 people who have the highest risk exposure will become Hep C positive. Okay, so now another question: how do we test the healthcare worker in the moment? What do we need to use for the healthcare worker? 1, 2, or 3? Back to 1, 2, 3. 1, don't test. Okay. 3, Hep C antibody. Yeah. You got to vote for Hep C RNA. Yeah. Like it. Okay. So this is a tricky one. I'm going to actually skip ahead to this and then we'll go back. So when we initially test, we actually do want to do the antibody with a reflex. So if you have, people, either one of those answers were correct, the antibody or reflex, because we really want both. On the left side, you can see that one reason we're testing is to find out if the healthcare worker already has Hep C. And that's not to blame the person, but it's important to know whether they got it from the exposure or if they already had it. So if they got it from the person from that exposure and they're tested, within the next couple of days, their body didn't have time to make antibodies. So if the person has antibodies with their initial test, that means that they already had Hep C. If they have a positive Hep C RNA, then they have active Hep C and we need to get them treated. If they have a negative Hep C, then we know Hep C antibody, we know they haven't been exposed. And so we're going to need to follow them up. Important to remember, because remember I said you can get Hep C again. If they had a Hep C antibody positive and Hep C RNA negative, that means either they cleared it on their own before or they were treated. But that doesn't protect them from getting it again. So they could still get it. So that means that we would follow down this diagram. If the flow diagram in figure one is what we looked at before. So if the patient didn't have Hep C, then we don't need to do anything else, no matter what the healthcare worker had. If that patient did have Hep C, then we need to continue follow-up, and we would check for the viral load in 3 to 6 weeks. The reason for that is because they still wouldn't have had time to make antibodies, but we would want to know if they had started producing copies of the virus. And if they did, if they're Hep C RNA viral load positive, we'd want to refer them to care. And we're going to talk about what that care would look like. If they are negative, then we follow them out a little bit longer and test them 4 to 6 months after exposure. The reason for this is that there can be, as your body tries to battle with the hepatitis C virus, there can be moments, not just moments, days, weeks, when there is no virus. And so that's why it's important to check again to see who won that war. Did your body win the war and there's no virus, or did the virus win and the virus is has taken up residence in your liver? Okay. What are some other issues that we'd anticipate discussing? I know I'm a little short on time, so I'm not going to ask for people to put it in the chat right now. But I do want to emphasize a few things. So sex, you know, this gentleman is married in a relationship. His wife is pregnant. He certainly doesn't want his wife to get hepatitis C, especially not while she's pregnant. And so that was definitely something that was on his mind. As I mentioned, vaginal sex is not a great way to get hepatitis C. So even if he were to develop it, he probably wouldn't give hepatitis C to his wife, but that's a conversation to have with each person. Of course, the safest thing to do is abstain. Probably the next safest thing is to use a condom. But again, the risk is quite low. You may have had experience in talking to people who may have been exposed to HIV. In the case of exposure to HIV, we would definitely recommend abstinence or condoms because the viral load gets very high early on. In terms of household transmission, just a reminder that it's not eating or drinking out of the same cups, not using the same towels. It's really anything that would break the skin. Potential treatment options, really important to remind people that there's a cure that we're going to talk about in a second. The other thing that a lot of people think about hepatitis C is that they can never afford the treatment. And it is true that the treatment remains extremely expensive, but it is also covered by most insurance. So whether it's a health workers' comp situation or a situation where someone needs to use their insurance, there are definitely options for paying for that. So a lot of reassurance in terms of these issues. So our nurse is unlucky. He's one of the this is not true actually, but he was not unlucky, thankfully. But for the purpose of education, he was unlucky. He is one of the 0.2% that seroconvert to become Hep C antibody positive and Hep C viral load positive. He is very healthy, doesn't take any medication. He's read the data that a lot of people clear the virus on their own. And he wants to know, you know, should I be treated or should I just wait? I'm just curious, this is just out of curiosity, if anybody's willing to share, what would you do? Would you want to be treated right away or would you want to wait and see? Treat. Mm-hmm. Yeah. Like you all, I would treat. And that's what's recommended. It is important to remember, and this may be particularly true if you're working with populations that are more on the baby boomer side of the curve. The treatment for hepatitis C used to be absolutely awful. I've been doing this for almost 20 years now, and back in the day, oh my goodness, we had to use interferon and ribavirin, and it was shots every week, and it made you feel like you had the flu, and it was a 50-50 chance of whether you got cured. Treatment was for a year. But things have really dramatically changed. You can see in 1989 was only when we discovered the Hep C virus. 1992 was when the blood supply became safe. You can see over this time period that, you know, the number of cases that resulted in death from liver disease really increased. But and then in 2011, we started to see an increase in new Hep C cases associated with the opioid use disorder. And this was a dark time because we still only had really crummy treatments. But in 2014, we actually had new medications that were all by mouth, that had many fewer side effects, and that actually gave us the opportunity to start dreaming about the elimination of hepatitis C. So you can see in this graph the increased rate of cure. So we document hepatitis C cure when somebody has had a negative viral load 12 weeks after they finish treatment. So that's what an SVR is the sustained viral response at 12 weeks. And you can see that early on in the early 90s, the cure rates were terrible. This is when I really started treating, when the cure rates were about 50%. But if you look here, and I will never forget one of my hepatology professors back when I was a resident being so excited about getting to 50%. Now I can't quite imagine it, but it was better. And now we're well over 95%, which is fantastic. And these medications are advertised a fair bit. There are two combination medications which don't have generics. So I did put the brand names up there, but those are the generic names underneath that are available for treatment that achieve those kinds of treatment of cure rates of over 95%. These medications are associated with very few side effects. Most people don't have any side effects. A small minority, less than 10%, will have some nausea or some headache the first week. So they're really remarkably well tolerated. So why should we treat it? Well, we've talked a lot about the liver. And what this is showing is that the liver actually gets better. Important to remember that even though I showed those really ugly pictures of the liver, even if you've had some scarring already, the liver is the only organ other than the skin that can heal itself. So this graph is showing this dotted line is people that didn't achieve a cure, and this solid line is people that achieve a cure. This y-axis is talking about liver stiffness. So you remember I talked about how nice and spongy a liver is supposed to be. Well, these folks up here, when they had Hep C, their livers were very stiff. When their liver got treated for Hep C, their livers came back down and became nice and spongy, which is reducing the risk of cirrhosis, eliminating cirrhosis, and reducing the risk of hepatocellular carcinoma. It's also fascinating to know that all-cause mortality, excluding substance overdose, is decreased by treating hepatitis C. So I really wanted to emphasize this in this group because I think some of you are working in long-term care facilities where there may be older individuals that have Hep C. It's not too late to treat Hep C. I mean, there's certainly people for whom, it doesn't really make sense to add in other medications, but there is potential life-prolonging and quality of life-prolonging benefit to taking to treating hepatitis C. And I didn't say at the beginning, but I have no conflicts, including no stock in either of those companies that make that medication. But people, there have been in large cohort studies demonstrations of improved lifespan and also some really important other health events that can be decreased, including acute coronary syndrome, end-stage renal disease, and stroke. I also want to point out how much better people feel. And sometimes that feels a little squishy. So I'm really grateful for this cohort that came out of Ukraine, actually. It wasn't a population of people who were receiving medication-assisted treatment for opioid use disorder. But as you can see from my very simple little graphs here, people between baseline when they had hepatitis C and after they were cured of hepatitis C had improved focus, dramatic decrease in fatigue, and even decrease in pain. So I cannot explain all of the reasons physiologically yet that this helps, but if you can imagine that virus pumping out of your liver and coursing through your body, you can imagine that, that certainly takes energy and also may be contributing to a variety of other ways in which you feel poorly. So this I think is really compelling evidence to think about treating. And I can tell you, having treated over 1,000 people for Hep C at this point, that I hear this all the time, how much better people feel. For those of you who work with people who are also struggling with opioid use disorder, I also find this quote very powerful. I mentioned the syndemic at the beginning, and that really gets ingrained in people's head. So this opportunity to help people feel like they're getting rid of the last hold that their addiction had is really kind of a wonderful thing to be able to do. And I love it when people just tell me that they feel. I don't love it completely, because oftentimes people tell me that they feel like their blood is clean. I hate the fact that they feel like their blood is dirty, but I'm glad that they feel that release once they're treated. So how are we doing with treatment in the United States? Well, this is data from 10 years ago that shows that of all the people that were chronically Hep C infected, only about half were aware. And we just marched down in terms of whether they had access to care, whether their RNA was confirmed. And this is the percent that had achieved cure. So you could say that's old data. Unfortunately, it has not gotten that much better. So initially, when the medications came out, there was a nice surge from 2014 to 2015 nationally in people being treated for Hep C. But you'll note this is even before the COVID-19 pandemic, that rates of treatment really dropped off, which is pathetic. Because we have a great treatment that can actually cure this disease. And unfortunately, this is occurring, as the CDC has emphasized, even in people who are insured. I mean, even for people with private insurance, only 1/3 of them are getting treated. And if we come to people with Medicaid, less than 1/4 of them are being treated. So this is really, in my opinion, a lost opportunity. And I hope that by spreading the word with opportunities like today, thank you, Anthony, that in your communities and in your work, you can encourage people to get that at least once a lifetime screening, and also let them know that there are opportunities for treatment, especially because Virginia is a fantastic place to treat Hep C. From this advocacy organization that strives to increase access to Hep C treatment, Virginia gets an A. I'm proud of that. And I mentioned Terry Kemp-Nick before. She is a nurse and a public health expert who has been advocating over the years and has achieved these various goals in collaboration with partners at DMAS. And in 2022, eliminating the prior authorization for those 2 medications was huge. And it's just so much easier to treat now. And we want to share that information. So if anybody's interested in treating yourself or bringing Hep C cure to your practice, the state sponsors us to give an 8-hour in-person or virtual training, which we usually give about quarterly. It's free. There are 8 hours of continuing education credits that come with it. And we also have a community of practice every month to follow up on issues related to Hep C and also to the opioid epidemic. So I will have the website up. Well, the website's right there. You can check that out. We don't currently have a training scheduled, but we anticipate that there will be one midsummer and then another one in early fall. There's also an online training that you can do independently. The University of Washington has one that is really excellent, also kind of dense, but also very good. And this is our goal. It's estimated that in Virginia, we could eliminate Hep C by 2033, which is pretty amazing. But I'd like to see us do it even sooner, frankly. So I'll end with this quote, which came from another one of our patients who told me after she had been treated that she felt as though she could breathe again, which meant the world to me. So with that, I will say thank you very much, and I'm happy to take questions. Okay, great questions, Tedra. I'm just going to turn my share off here. All right. In terms of what needs to be done prior to initiating treatment, there is a very helpful guideline that I will put the link in the chat that gives you the expedited treatment and tells you sort of inclusion exclusion criteria. The short answer is that you need a CBC, an AST, ALT, a Hep C viral load, and a hepatitis B surface antigen and HIV test. So those are the absolute minimum labs that need to be done. In terms of people who are still using substances, the evidence-based practice that is recommended by all of the societies in the United States and Europe recommends treating people no matter what their current use is. The reason for that, in part, is that we want to decrease stigma. Also, those are the folks that are probably most likely to spread the disease. Also, it's a great opportunity to talk to people about harm reduction. Trying to work with folks to be able to use more safely is one aspect, but also I have found that folks who have come in and taken that step to improve their health by getting their Hep C treated, many times they're open to thinking about other strategies to improve their health, including maybe considering some recovery pathways. What is believed to be the cause of the decrease in treatment seen since COVID? That graph that I showed was actually all pre-COVID. The decrease since COVID is, I believe, largely just due to competing priorities. For example, when we worked very closely with the health departments down in far Southwest Virginia from 2017 to 2020. In their context, they do a lot of medical care through the health departments. All the nurse practitioners that staffed the health departments were all treating Hep C, as an example. When the pandemic started, that all stopped just because they couldn't do all of the COVID stuff plus treating Hep C on top of that. And I think that happened in a lot of places, even though, you know, Hep C can be treated with a single visit. I do a single visit for people and then am very fortunate to have a nurse navigator that helps me with the follow-up, but it's really a single visit and a single lab test 6 months later. So it doesn't have to be a huge undertaking. There are also programs like ours that will do treatment through telehealth. There are others that will do that too. And if you visit our website, we have a treatment map that indicates the places where our people that we have trained are treating, and also is color coded so that you know what insurances are accepted, and also whether or not people are following guidelines about the elimination of drug testing and sobriety testing, because it's never any fun to send somebody to a place where they're going to be sent away because they're still using. Better to send them to a place where they can actually get care. Hold on just a second. I'm going to grab that site for you, I think. But also, please, welcome to come to our training. It's a lot of fun. Hi, Juana. Oh, sorry, my computer's being slow. Any other questions? I really appreciate all of your participation. Well, let's see. I need to message everybody with this. So this is these are the guidelines for treating Hep C, and there are the there's the simplified regimen. Oh, the hi Tabor. And some people will feel comfortable undertaking that on their own, but if not, feel free to join our community of practice or to come to the training.
I'm always struck by the county maps of Virginia, and just they almost look the same for across so many different health metrics. With respect to your the Hep C Virginia, do you have like specific strategies to reach underserved areas?
Yeah, that's a great question. So we certainly started with our focus in far Southwest Virginia based on the epidemiology, and spent a fair bit of time down there meeting with community members and with practitioners, and finding out both what their concerns were about treating Hep C, and also what they saw as the opportunities. So I think in any undertaking, that's always one of the most important things. And then secondly, we've worked very hard with the Department of Corrections and with jails in various communities to ask them to provide direct referrals, which they have done. We've also worked closely with networks of substance use treatment programs. So a lot of the substance use treatment programs either have gotten training themselves or have started referring. And then it's sort of a cascade effect, as people are like, well, have you thought about putting up a flyer in the parole office, or what, even like bathrooms in various places. So kind of just like keeping our ears to the ground and finding out. We also have a lot of word of mouth in terms of just patients that have had treatment. We on our website have self-referral, and we accept those without question. Just yesterday, I had a young man who had self-referred through the website, and he was telling me how much he appreciated that, because he's someone who's really struggled with polysubstance use disorder and also has chronic pancreatitis, and he feels like whenever he walks into a doctor's office, he's judged, before he even sits down. And so I think that really working to decrease barriers. We and others see people through telehealth, not with an originator site. So, we see people at their job sites, on their breaks, that sort of thing. And that also seems to really help, just trying to meet people where they are. Any suggestions for how to handle DOC does not pay for treatment with inmates? So Department of Corrections for prisons does actually pay for treatment of inmates, and they've done a really good job. A number of the pharmacists that work for the Department of Corrections have gone through our training, and they've actually in the past couple of years treated 1,500 patients. So in prison, it's less of a problem. Yeah, local jails are a big issue. And that's something we're still working on. We try to work kind of jail by jail with the different clinicians. As they do, it's true, they do not cover treatment. They will sometimes allow treatment to be brought in, but unfortunately, we have not found a system-wide strategy across all the different counties to be able to achieve the goal of getting people treated or allowing them to continue their treatment when in jail. But so far, really the best success we've had is just kind of going, trying to develop a personal connection. It's ongoing. I know that it's such a perfect population to treat, and in the prisons they've done a really good job, but the jails it's tough, and especially because so many people unfortunately are held in jails for a tremendously long time. It can be a real issue.
Dr.
Thank
Dillingham,
you.
can you hear me?
Yeah.
I'm sorry.
Hi, my name is Juana. I am the nurse care coordinator for hepatitis C at UVA. I had a patient who reached out to me wanting to get treatment for hepatitis C, but they are far down in that southwest area in Tazewell.
Yeah.
So when I went to Virginia C, and she was hoping, she doesn't want to have to travel all the way to Charlottesville, which I can understand, that's a big barrier.
It's very fun.
So on the Virginia Hep C website, I see that there are kind of two options. So I saw one, the treatment access map. And on here, I contacted one of the Southwest Virginia Community Health Systems. And when I spoke with one of their case managers, they said that they don't treat hepatitis C. And so I'm kind of wondering, and I see on here there's like yellow locations that say verified access, and there's blue, which is Hep C trained. And I was just kind of wondering what the difference of those two, what they mean.
Yeah, so the verified access is supposed to mean that they are actually accepting patients. So for Tazewell, I would probably send them to one of the health departments, because the nurse practitioners, they might have to go one county over, but the nurse practitioners down there do a ton. So let's see, I see what you're saying, Southwest Community Health System. I'll have to ask Terry about that one. But I would, let's see, if I know at the Dickinson Health Department, and definitely at Scott and Lenawisco and Cumberland Plateau Health Department, all of those, they all treat Hep B. And also, if you want to send me an email, I'd be happy to get one of the nurse practitioners to help us facilitate that.
Okay. And then, so kind of the other, link on here is the find treatment, and patients can request an appointment. Is that an appointment with you? Is it an appointment just to kind of help them find resources nearby?
So if they request treatment, what happens is one of our nurse navigators calls and asks them, where they are. Do you want to be treated in person nearby? And then we make a call to see about having somebody get an appointment nearby, or we offer them treatment through us. Yeah.
All right, so I could call that patient and offer them this resource as well to get started.
Absolutely. We would be more than happy to get them plugged in down there. And I have a ton of confidence in those nurse practitioners. Unfortunately, they treat a lot of Hep B.
Okay. All right, perfect. I think those were all my questions, so thank you so much.
No problem.
Well, thank you so much. That was a really engaging conversation. I learned a lot, and it was, I really appreciate it. I think I would say this was the most engaged an audience has been thus far. And so that was outstanding. Thank you, Dr. Dillingham.
Thank you.
And that's all. I look forward to some folks attending next month. June 12th is the session on an innovative approach to the treatment of HIV, positive links, with Evelina Waldman. And so same time, 12:30 to 1:30 on June 12th next month. Thank you all for your time.
Thank you. Bye-bye.
Take care.